Hello and welcome once again to APHA's 15 on COVID-19 series. I'm your host Dan Zlott, Vice President of Education here at APHA. Today we're going to be talking about dexamethasone. There have been a couple of interesting publications that have come out regarding the use and utility of dexamethasone in COVID-19. So without further delay, let's go ahead and jump in and take a look. I have nothing to disclose, and here are your learning objectives for today's episode. All right. Well, before we jump into understanding dexamethasone and its role in COVID-19, it's helpful to take a step back and review some of the complications, or in particular, the immune-related complications of COVID-19. So if you've viewed some of our prior episodes and you've followed the series all along, some of this will be reviewed to you. But for those of you who are new, it turns out that the evidence from COVID-19 patients shows that it's actually not so much the virus that causes many of the severe symptoms that we associate with COVID-19. In fact, it's actually our immune system's response to the virus, and in particular in the lungs and in several other organs, that seems to do all of the really severe damage that causes the moderate to severe symptoms of COVID-19. And we know this because on autopsies or postmortems, we actually see the presence of highly activated immune cells, which is another way to say T cells mostly, but there are other types of immune cells as well, in lung tissue, heart tissue, and even the liver and some other organs. So that tells us that there's ramped up immune activity going on in multiple organ systems. Additionally, they found high levels of highly activated immune cells, again, mostly T cells, in the blood of patients with who passed away from COVID-19. So all of that kind of ties together this idea that what we're actually seeing in a lot of these severe patients, moderate to severe patients, and certainly in patients who pass away from COVID-19, is that there's actually significant immune damage going on to organs and in particular the lung tissue. So continuing with the trend that many of the severe symptoms that we see in COVID-19 patients is immune mediated, it turns out that when you start looking at some of the markers of inflammation, in particular cytokines and interferons and interleukins, things like that, you see significantly elevated levels of those markers as well. In particular, interleukin 2, IL-6, IL-10, and tumor necrosis factor alpha. Again, all of those are very generic and broad markers of inflammation. And interestingly, when you look at patients who have moderate COVID-19 or severe COVID-19, there are statistically significantly different levels of those inflammatory markers in between moderate and severe patients, with severe patients having higher levels of those inflammatory biomarkers. So we know that dexamethasone is a potent immunosuppressant and in theory can help to quell this hyperactive immune response that's resulting in organ damage. So that's the pharmacology behind the application of dexamethasone to COVID-19. So let's take a look at a study. So this is actually a trial conducted in the UK. It's called the Recovery Trial, and it may sound familiar to you. We also talked about it with some of the hydroxychloroquine data that came out. So the Recovery Trial is a randomized, controlled, open-label trial in about 6,500 patients, at least for the dexamethasone arm. There were several arms to this trial, including hydroxychloroquine and others. And the trial was conducted in 176 institutions across the United Kingdom. The intervention that was studied in this arm of the trial, at least, was dexamethasone, 6 milligrams, either orally or intravenously, every day for 10 days, versus the standard of care. In the way that they accrued patients, they did a 1-to-2 ratio, so 1 patient in the intervention arm to 2 patients in the standard of care arm. So there were about 2,100 patients in the dexamethasone arm and 4,300 patients in the standard of care arm. So the patients themselves were hospitalized patients with clinically suspected or confirmed COVID-19. Now this is sort of interesting because almost every other trial we've looked at, they positively confirmed that patients had COVID-19, typically by PCR or some other test. PCR is by far and away the most common modality that we're seeing used to confirm patients' COVID-19 status. Interestingly, this cohort included patients who are less than 18 years old, as well as pregnant or breastfeeding women. So that's a little bit of a change in patient population than we've seen before as well. Again, because it's a randomized trial, the breakdown of these types of patients in both groups, the dexamethasone group as well as the standard of care group, was equal. So no bias there. It's just an interesting twist or a difference compared to a lot of the other trials that have been conducted. The exclusion criteria were fairly vague, a medical history that might put the patient at significant risk if they were going to participate in the trial. So that's the exclusion criteria. So very much at the investigator's discretion there. The outcomes that were being studied, the primary outcome was all-cause mortality within 28 days of randomization. Secondary outcomes were time to hospital discharge, and then in patients who, at the time of enrollment, did not require mechanical ventilation, the progression to mechanical ventilation. So what were the results? Well, looking at the primary outcome, the 28-day mortality was 21.6 in the dexamethasone arm versus 24.6% in the standard of care arm. This is for all patients, all comers, and the relative ratio there was 0.83. The 95% confidence interval was 0.74 to 0.92. So as you can tell, that does not cross 1. And so when we're talking about risk ratios, relative risks, odds ratios, etc., 1 is the magic number for our 95% confidence interval. So since it does not cross 1, that is statistically significant. And for good measure, they calculated a p-value there for us, which was highly statistically significant at less than 0.001. Now, when you look at some subgroups, in particular the group of patients who required invasive mechanical ventilation, we see even better outcomes. The 28-day mortality in the dexamethasone group was reduced by 35% as compared to the standard of care group. So the risk ratio there was 0.65. And again, the 95% confidence interval is there for you. You can see it does not cross 1, and the p-value once again is highly statistically significant. We also see some increased benefit in patients who required oxygen support, but not mechanical ventilation. So those would be patients who require O2 via nasal cannula, high flow O2, something along those lines. And there, the 28-day mortality, the dexamethasone in the dexamethasone group, was reduced by 20% as compared to the standard of care group. And again, the 95% confidence interval is there for you. Once again, it does not cross 1, and we see a p-value of 0.002, indicating statistical significance. So we definitely see significant reductions in mortality in the dexamethasone group as compared to the standard of care arm. Interestingly, there was no mortality benefit in patients who did not require respiratory support. So if you did not require oxygen or mechanical ventilation, and interestingly, we'll see on the next slide, not only was there no benefit, there was actually a little bit of a trend towards a harm, and we'll talk about why that may be when we get to the next slide. So this is just a visual of the same information we just presented on the previous slide for those of you who like things visually. So the percent mortality is on the vertical axis there, and it goes from 0 to 50%. The higher the number, obviously the more people have died from COVID-19. And then on the horizontal axis is the time or days since randomization. And so the usual care is in a solid black line. Dexamethasone is in a dotted red line. And so in the panel A, this is all comers, and you can see that there's a decreased that the lines separate very clearly almost from the outset, and that the dexamethasone arm remains below the standard of care arm or the usual care arm throughout. Now, interestingly enough, as we just discussed in panel B, we see that the all-cause mortality in patients who did not receive oxygen was actually higher than patients who received standard of care or usual care. And so this was not statistically significant. However, some speculation as to why that may be. In patients who don't have severe disease, they are not experiencing such a massive immune response, and so it may not be necessary to suppress the immune response. And in fact, by suppressing the immune response in those patients, what may happen is that we're actually allowing the virus to replicate essentially, and instead of allowing those patients to clear their infection, we're suppressing their ability to clear their infection. And so that's one hypothesis, and it is just a hypothesis, as to why dexamethasone may not be beneficial in the group of patients who did not require oxygen at the time of randomization. So panels C and D again show the benefit of dexamethasone in patients requiring oxygen only in the case of panel C, and patients who required invasive mechanical ventilation in panel D. And again, you can see a clear separation between the usual care and the dexamethasone lines. Those clearly separate, and both of those were statistically significant. So looking at secondary outcomes, interestingly, patients in the dexamethasone arm had a shorter hospital length of stay than patients in the standard of care arm. It was 12 days in the dexamethasone arm versus 13 days in the standard of care arm. The authors did not provide statistical outcomes there, so I don't know if that's because they were not statistically significant or because they did not have enough power to detect the difference, but either way, we don't know whether or not those were statistically significant. The authors didn't comment on that. Patients in the dexamethasone arm had an increased probability of being discharged alive within 28 days of randomization. You might suspect that given the survival outcomes that we saw as well. The rate ratio was 1.1. So again, you're 1.1 times more likely to be discharged alive if you receive dexamethasone as compared to standard of care. The confidence interval is there for you, 1.03 to 1.17. It just barely misses crossing that threshold of 1 that we always talk about. So that was statistically significant. Interestingly, also in patients who did not require mechanical ventilation at the time of randomization, there was a trend towards a lower rate of progression to mechanical ventilation or death in patients who received dexamethasone as compared to those who received standard of care. Again, this was not statistically significant. The risk ratio is 0.92. The 95% confidence interval, as you see, is 0.84 to 1.01. So again, because it crosses 1, it is not statistically significant, but it's very close. So that's why we call it a trend. So what were some of the limitations of this study? Overall, this was a pretty well-designed trial. Most of the limitations are a little bit nitpicky, and so we'll go through those little nitpicks. Not all patients had confirmed COVID-19 disease at the time of randomization, so they did accept patients with clinically suspected COVID-19, and so there's a possibility that you got into the trial and you didn't have COVID-19. It's probably a relatively small risk, but it is a risk that does exist, so we do have to keep that in mind. Now, one might argue that given the fact that we're talking about the treatment of something that looks like COVID-19, we probably should treat it like COVID-19 given the fact that it's pretty active in the world right now. And so it's hard to argue with that thought process. So even in a patient who didn't have confirmed COVID-19 based on this trial, if their symptoms were strong enough that you suspected COVID-19, it may be worth considering dexamethasone. So again, one little nitpicky limitation to the trial. Again, a very nitpicky limitation. They really didn't collect anything related to viral shedding. And the reason that's important, one of the big concerns when you talk about immunosuppression in patients with viral infections is the concern that you will lengthen the period of viral shedding. And so it would have been interesting for the authors to have collected some of that information to see if there was any difference in terms of the length of viral shedding in patients who received dexamethasone versus those who did not. Now, whether that tells us anything clinically relevant, that's another question, but that has always been one of the concerns raised when you start throwing immunosuppressants at a patient with a viral illness. And so had they been able to answer that, that would have also been able to answer another question that we have about COVID-19. So what's the bottom line? This was a very well-designed trial. and it showed very clearly that dexamethasone improves survival outcomes in patients with COVID-19 who require supplemental oxygen support or mechanical ventilation. And as we mentioned, there was a trend towards harm in patients who did not require oxygen supplementation at the time of randomization. So what this helps to highlight for us, as is always the case, is the idea that patient selection plays an important role in maximizing the benefit of any therapy that we choose to utilize. And in this case, it's not just that there's a lack of benefit, there actually may be an active harm to administering dexamethasone to someone who is not appropriate. So that will wrap up today's 15 on COVID-19 episode. Thank you very much for joining us. Our next episode, to be released on August 7th, we'll be looking at adenovirus vaccines for COVID-19. Again, with the recent resurgence in COVID-19, there's a lot of interest in vaccines and vaccine development. So we'll take a look at this adenovirus vaccine technology, break it down a little bit for you, and examine some of the available data. We hope to see you on Friday. Until then, if you have any questions about COVID-19, please email them to us at covid@aphanet.org. A huge thank you to those of you who've submitted suggestions. We find those incredibly helpful in terms of planning future episodes, and we look forward to receiving your suggestion. Thank you once again for joining us, and we hope to see you on Friday.